Vice President Jeff, Rotary Club members and guests. Almost every newscast that we hear or see now seems to include some reference to the opioid overdose crisis. At first, it appeared as though this was only applicable to cities like Vancouver and Toronto. Now we're shocked to learn that our city has the same level of concern. What are we doing about it? So today we're having Shaya Dhinsa, and she is certainly very competent. She grew up in the St. Thomas area, earned a baccalaureate degree in nursing, Masters of Education from Western. She's a manager of the sexual health program at the Middlesex-London Health Unit and has been for the last 9 years. We look forward very much to your presentation and welcome to our meeting.
Hello, thank you for having me. So for the past 6 months, I've been focused on the opioid crisis here in London and supervised consumption facilities. So I was also a part of the 9 consultations in the city. So just a little bit, the health unit, the main office is located here on 50 King Street. There is also a sub-office which is located in Middlesex County in Strathroy. And the health unit serves about 450,000 people. 381,000 is through the City of London and 71,000 in Middlesex County. There is a total of 275 full-time equivalent staff at our health unit. So moving on, so there's multiple overlapping drug-related crises in London. It's just not one issue. There's lots of issues that make up the crisis that's happening in our city. So one of the ones is that there is overdose deaths. So in the last 10 years, there have been 400 people that have died of opioid death here in the City of London. So just to kind of put in perspective, I've also said this is mothers, fathers, children's, brothers, sisters. So it can be, it does impact people. It's not just those people out there. So it has impacted lives here in the city. We have implemented naloxone. So you might have heard that in 2014, our overdose related deaths were higher than the provincial rate. So we looked at what are we going to do? First thing is naloxone. So getting these kits. Naloxone is a medication that reverses overdose. Might have heard of it as called Narcan. So we worked with Middlesex-London Health Unit, London Intercommunity, and Regional HIV/AIDS Connection and implemented these naloxone kits. In the past few years, things have changed. They were injectable. You could only get them at these 3 locations. Now you can get them at pharmacies. You can continually get them at our 3 locations. But in the last several months, they expanded the criteria. So people can now go to shelters and access. So the key is to distribute and get them in the hands of those that are using. So shelters have been trained, withdrawal management programs have been trained, outreach teams have been trained, Community Access Center, including SOHAC, has also been trained. First Nations communities, I've been out there and provided training. So we've provided since September and October over 700 kits in the community. I don't have my graph here, but what my graph shows is that in 2014 we were hardly giving any kits out, and therefore they were hardly being used. The last quarterly report, there's one due today, so I don't have recent stats, but from July to September, we gave out 212 kits, and that's great that they are now getting in the hands of those that are using. But then there was also, it's kind of a good news, bad news story, is that 24 reversals happened in that time frame. So 24 people's lives were saved, which is really great, but unfortunately we're having to use these kits to save people's lives. So that's one way we've been trying to prevent overdose deaths here in the city. One of the other is HIV outreach or street nursing. So back in 2016, the health unit declared an HIV crisis. So to put in perspective, that year we had 59 cases of HIV. In the same year, all of British Columbia only had 20 cases of people who inject drugs of HIV, and we had about, out of 59, I would say 50. So that puts, and we're just London. So that spoke, okay, we've got a situation here, we need to look into it, what's happening? It is different than the rest of the province. Their rates are decreasing and ours are increasing. Also in the rest of the province, many of the cases that were positive were men who have sex with men. They were not people who inject drugs. So this again spoke, we have a drug use problem here in the city, and people are sharing their drug use equipment. I was lucky enough to fly to Vancouver to look at how did they change it, right? They do have an opioid overdose crisis there, but they also have decreased rates of HIV spreading among people who inject drugs if they only had 20 in all of their province. So they had an HIV stop program. So this is a program where there's nurses, outreach workers, and social workers that actually work at the street level, engaging people who are at risk for HIV, as well as people who are at risk for hepatitis C and invasive group A strep. And what they did is they engaged the population and kind of went with their plan. Okay, so you want housing? Let's look for housing. You want addiction? Into detox, we'll connect you. So I spent 2 full days down the downtown east side really understanding their role. And we brought the same program here in London. Obviously, we tailored it to our city. And we have currently 2 outreach workers and a nurse who work in this program and an HIV program lead. The program came together this past June by the time we hired. There are 90 people on this caseload, and of the 90 people, 85 are in care. So that means these are people who were not engaged in any care. We could not find them, and now they are connected to care. When I say care, it means treatment. So they may still be actively using drugs, but if they are sharing their equipment, they are not transmitting HIV. So that was another program that we looked at here in the city. You might have heard a little bit about endocarditis. It is not a reportable disease, so it does not get reported to public health, but it does affect the acute care center hospital. They are getting about almost 8 referrals daily for people who are dying of endocarditis or they're being admitted and need antibiotic treatment. So what this is an infection of the heart valves. And it's because people are using drugs. They're either using their equipment, they're sharing, and they're getting this infection. It is treatable by antibiotics, but in some cases, people get very, very ill and need heart valve replacement. And then if people in hospital are addicted and they aren't getting kind of methadone or any sort of treatment, they will discharge themselves. Or they leave the hospital and they're still involved in those unsafe practices. The fourth one is quite a common one, I'm sure every single person has heard, is litter, right? A lot of people are discarding needles on the streets. We give out over 3 million needles here in the city. That is more per population than Toronto. Again, that speaks to that there are people who are getting needles and they need them, but the unfortunate side effect is that they're being discarded improperly. There are needle bins in the city. There is a London Cares team that responds to 24/7 to pick up needles in public places only. Again, they get very busy and cannot get out there as quick. One of the other things the health unit has started is there is a SERVE team, so the Community Emergency Response Volunteers. Some of them have been very interested in this concern and are now out in the community. The snow has delayed or deterred the team. It's hard to find needles when they're underneath the snow. So once there's a little more of a melt, they'll be back out again, and they are hitting the hot spots in the city. And these are hot spots that have been identified by London Cares or downtown London. So that is something we are trying to focus on. We are well aware that people are littering. They actually are using, kind of sliding into the next topic, public drug use. So people are using in parks, alleyways, behind businesses. We do know that. That's where we find them. And when we did a peer focus group as part of the community consultations, it was identified that yep, I'm at a couple shelters. I have to leave for the day. I'm highly addicted and I need to get high. Where do I go? I have nowhere to go. So the places they indicated were the places where we're finding the needles. So that was part of the consultation piece. It also identified, or they confirmed to us, they really want somewhere to go. So again, looking at a supervised consumption facility, is anyone going to use it? That was another confirmation that they would be glad to have a place to use. It would be safer for them and safer for their community. They did identify that. So there's also the costs to the community. So we put a little bit of information together. So an HIV, a single case in a lifetime can cost $1.3 million. London's outbreak each year is $50 million. So our outbreak with the 59 cases, they weren't all people who inject drugs, but you can see the impact of the outbreak that we've experienced. Endocarditis is 7.5 million, so that's impacting the acute care center here in the hospitals. Hepatitis C. So there is treatment for hepatitis C, which is great news. People can be treated and cured, but the cost of that is $70,000. Hepatitis C is predominantly spread through sharing of injection drug use equipment. And treat all existing cases in London. So therefore, it's $210 million. So this is the cost that's costing our community because of these infectious diseases. Okay, this is a crazy map or a graph, but what it's basically showing is that the monthly rates of opioid-related emergency department visits. So this is over a great period of time of 2003 right up to March 2017. So it's showing the blue line is the Ontario rate, and it's slowly increasing with the emergency visits related to opioid use. And then you can also see it's kind of crazy, the orange line, but it's also increasing and slightly above the rest of Ontario. So again, speaking to the issue that we're facing here in the city. So kind of moving on to supervised consumption facilities. So with all these issues happening, we thought, well, what else? How do we keep people from, not discarding needles, using drugs safely, getting access to equipment? And so the supervised consumption facilities kind of came to our attention. You might know of supervised injection site. This is the exact same thing, except we say consumption because people may not be injecting. They could be snorting or just orally taking opioids. So again, that is still a risk for overdose. So we want to encompass that that clientele could access this service. So a little bit about supervised consumption facilities. You just can't open one. You need federal exemption because illegal drugs are used at a facility like this. This will exempt a facility from being charged and the individuals inside being charged who bring their pre-obtained drugs. So that's another thing. We don't supply drugs. You have to bring your own. It is a clean, sterile environment. You get all your supplies that you require, and therefore you are already injecting safely. So therefore you're not sharing and you are not reusing. There is a nurse on site. So this is a nurse, someone who can monitor the client who's injecting. You don't just come in and sit down and start injecting. You actually have to have a quick assessment. Have you used this drug before? When was the last time you used? There is some information collected because the nurse is monitoring the client when they are injecting. And the nurse is there if there is a potential for overdose, right? The nurse can respond, provide naloxone or oxygen as needed. Again, so the key piece for me, and I know it was very important through the community consultations, was that a link to other services. It's not just go in, inject, and leave. It is supposed to be an integrated site. So this is not just injection. And when I say integrated, it can be addiction services, mental health services, housing, someone who's just a peer navigator, right? Where do I go? I need this, I need that. I have no ODSP. I don't have any money, or I'm not really sure what I want to do. I just need to speak to someone. Part of our community consultations included Indigenous focus groups, and they expressed that they wanted to be a part of this supervised consumption because Indigenous population would like to have a connection with someone who also is an Indigenous. So there's also peers, right? That was extremely important, and that came from those who inject drugs. They'd like to speak to someone who no longer uses drugs. How did they get there? What do I need to do? What are the services available to me? The piece is that there's 3 sections of supervised consumption. Is intake, so where you speak to the nurse and kind of talk about what drugs you're using. There's the injection room, and then we call it the chill room or post-injection room. That is where the connections are made. So the client it's supposed to be an environment that's welcoming. They will not feel stigmatized. They will not be judged. There will not someone come right up to them and say, hey, you want to get into addiction services. It will be when they're ready. It will be forging those relationships so they're comfortable. So that is kind of the key pieces of the supervised consumption facility. There was a feasibility study done in the city it was done in 2016, and the release of the results was last February. 200 people who inject drugs were interviewed, and 72% shared that they inject in public places. The other piece is that 98% expressed they want help. They really want help. They want support. They want to be connected to services, and they would use a facility. So again, what does it address? It addresses a nurse with an naloxone in the room, so that decreases overdose deaths. HIV, there'll be a reduce of spread because they are not sharing equipment. Endocarditis, you're getting clean injection equipment. You are also getting education around clean injection practices. Litter, you discard your equipment when you leave this facility. And public drug use. Now people have a safe, clean place to inject. So the other piece is that this isn't going to solve it all. I wish it would, but it won't. There has to be a larger strategy. So there is a community drug and alcohol strategy that has been in the city for the last few years with a fair amount of community involvement. It is co-led. It is not just the health unit. It is a community-led group. And it's a long-term process, right? So they're focusing on the 4 pillars approach. So they focus on enforcement. How do you target those who distribute large volumes of drugs? They focus on treatment. What sort of treatment services do we need in the city? They focus on prevention. How do we prevent people from getting involved in drugs? And then they focus on harm reduction. So harm reduction is where the Opioid Crisis Working Group, so this is a working group that's been kind of pulled together with some leaders in the city. And from that, supervised consumption. So supervised consumption falls under one of the pillars. So it's not going to be the solution. It is part of it. The other piece is, and I mentioned a little bit, Indigenous people in this community have experienced generations of suffering. So it was really key as part of the focus group is to involve the Indigenous population. So we did both urban and in First Nations communities to get their thoughts and feedback, how we can also involve them in this supervised consumption facility, because addiction is also quite prevalent in this population as well. And so part of it is walking alongside and learning what their needs are as well, and how to incorporate them in a supervised consumption facility. These are all the organizations that are currently, all these organizations right now are currently involved and have committed to working with us with a supervised consumption facility. One thing I was going to mention, because I'm guaranteed I'm going to get asked a question on this, is overdose prevention sites. So in the paper or on media, you might have heard, okay, now we're hearing about overdose prevention site. What's the difference? Like, how did we flip to that? So a supervised consumption, as you can see, it's a facility, it's a permanent site. You get permanent exemption, it's a wraparound services. It's a very well-funded model. It is a model that is funded by the Ministry of Health. It does not take from programs within the city. An overdose prevention site, you might have heard of them. They were illegally sanctioned. So they were popping up in British Columbia, they were popping up in Moss Park in Toronto in response to very significant overdoses. No one was shutting them down, because who wants to shut down these tents when they're saving lives? So the Ministry of Health has and Health Canada have agreed that overdose prevention sites should be opened. But there's an application process, and you can get temporary exemption. So it's not as rigorous as a supervised consumption facility application. A supervised consumption facility application is quite rigorous. You need community consultations, policies and procedures based on the community consultations. What were the concerns? What are the benefits? What are the safety features? There's quite a lot of information collected. For an overdose prevention site is an emergency measure. It is a measure to respond to overdoses, and it's temporary. So it is not a permanent site and will not be funded permanently. The idea is that a supervised consumption facility would be opening up. Quickly, I'll just say there are other major gaps. Medical detox, residential rehab, we are aware of that. It doesn't fall, unfortunately, in public health realm, but we are working with programs who will advocate for this. Again, looking at risk youth. Poverty, employment, housing, and social assistance is always an issue. So how do we incorporate that? And then broad multi-sector commitment to reconciliation and decolonization for the Indigenous population. I am happy to take any questions or concerns or anything you'd like me to pass on, or maybe I can answer them for you. Yes. The lady there?
Yeah. Yes, I'm interested in the litter problem. Our
Yes.
community association is in Blackfriars.
Yes.
We have a lot of litter along the river, and
Yes, you do.
We talked about asking, seeing if we could get a litter box.
Oh, yeah.
Are they used?
The boxes, quite heavily used. That's the piece that it's becoming a bit of a challenge, is that the more boxes we put out, which are needed, it's ensuring we have the appropriate staff to empty them, right? Because then it becomes pointless if they're full. We have purchased 6 new large boxes at the end of the year. They take 6 to 8 weeks to come in. So we are committed to working very closely actually with the City of London to ensure that, okay, besides, people going out and picking up, what else do we need? So the litter boxes or the large disposal boxes 6 have been purchased. I do usually show a map. And the map usually shows that discarded needles. I do have a map. It's not a perfect science because it's only the map of the phone calls that London Cares receives. So some people may pick up their own needles, and it doesn't include private property. But what I was trying to show with the map is that discarded needles are everywhere in the city. It is not just in the downtown area. Some people will say, well, why was it in North London? It's everywhere. It is predominantly in 4 areas of the city. That is also with hepatitis C, and that's where we get kind of the downtown core, the Soho area, Old East Village, and East Hamilton, and it just happens to be predominantly, so that's been our area of focus, but it does happen everywhere in the city.
Well, before you sit down, on behalf of the Rotary Club of London, I'd like to thank you for a very informative and timely topic to discuss today. And on behalf, the Rotary Club of London will be making a donation to Polio Plus campaign, and will be immunizing 50 infants in your name.
Wow, great. Thank you so much. Thank you for having me. Thank you.
Thank you very much.